Thank you very much. It is my pleasure again to present here in beautiful Puebla. And this is the title that I was given. And I always show this slide, maybe you know it already. It is not scientific, but it shows the satisfaction of patients over the years with the treatment with their acid inhibitors. It seems not to rise any further, this satisfaction, whereas we have stronger and stronger acid inhibitors. And I would predict that if we would have a drug that would 100% block gastric acid secretion, that satisfaction would still not go any further. This is not scientific, although it's true, but this is a scientific stride showing the number of patients who have not complete resolution of their symptoms. For instance, the top one, heartburn, 40 to 50% of patients do not reach complete resolution of symptoms. And it doesn't help very much, or not at all, to use a stronger drug or a higher dose. We have reached a plateau of the percentage of patients that will respond with complete resolution of their symptom, heartburn. What do we mean if we talk about refractory heartburn? Do we mean complete resolution of 50%? Do we mean on a single dose or a double, or is it after 4, 6, 8, or 12 weeks? You take your pick. And Sifrin and Zerbib proposed to use the ones indicated by the arrows here, but still you will see many different definitions of refractory heartburn. Here is the list of the mechanisms of heartburn refractoriness that I will go through successively. And the most important one for clinical practice is the top one. That is that the patient has heartburn but doesn't have reflux disease. And at least 1 out of 3 patients with PPI refractory heartburn doesn't have GERD. How do we know that? We know that because of studies using 24-hour pH and impedance monitoring and looking at the correlation between symptoms and reflux. And as you can see here, 30%, the blue pie chart, part of the pie, has functional heartburn. Esophageal pH monitoring makes it possible to measure esophageal acid absorption, but also the temporal association between symptom episodes and reflux events. And for this, you have the symptom index and the symptom association probability. If you use this technique, you can divide the world of heartburn sufferers into 4 groups. A group that has excessive acid exposure and positive symptom association. They have symptomatic GERD. You have a group that has physiological acid exposure and a positive symptom association. They also have GERD, but they are what we now call hypersensitive. Reflux hypersensitivity is the word you should use according to Rome 4. Another group has excessive acid exposure, so you may think they have GERD, but their symptoms are not associated with the reflux. So we don't know what causes their symptoms. And the last group has physiological acid exposure and a negative symptom association, and they don't have GERD. They have something else, probably functional heartburn. And the patients on the right side will never be helped with any form of anti-reflux therapy. In the Rome 4, you have these 2, functional heartburn and reflux hypersensitivity. This is a repetition of what I just said. In functional heartburn, there is no evidence that the symptoms are related to reflux. It doesn't belong to the reflux domain. And in reflux hypersensitivity, there is evidence that the symptoms are triggered by reflux, but the acid exposure is normal. It has been said over and over again that PPIs are less effective in NERD patients, non-erosive reflux disease patients, in comparison with those who have esophagitis. This shows the percentage of patients with complete symptom relief in a meta-analysis. But if you define NERD carefully, that if you require that they not only have negative endoscopy, but that they have a positive symptom correlation or a positive pH test, then you can see that the patients with NERD are as responding to a PPI as patients with esophagitis. Impedance measurement has made life a bit more complicated but more interesting at the same time, because you can not only look at the acid reflux but also at the non-acid reflux. And as most of you will know, if you have patient measured off PPI, you miss about a third of the reflux episodes when you don't use impedance measurement, because a third of the reflux episodes is non-acidic. On PPI, it's the other way around. Only a third is still acidic and 2/3 is non-acidic. So if you don't use impedance, you miss a lot of the reflux that is going on. This is a study in the same 30 patients that were studied off and on PPI. And in the end, you can see that the SAP, the symptom association probability, was positive in 15 of the 30 patients off PPI and in 11 on PPI. And that is a reason preferably to measure off PPI. But if we would have not have used the impedance data, but only looked at the pH data, then the bottom line shows you that there were much fewer patients who had a positive SAP or had a positive SAP. So by adding the impedance monitoring, you can see the importance of non-acidic reflux episodes for the generation of reflux symptoms such as heartburn. This slide you have seen before, but now it has been expanded by a breakup of the patients in the pink area, the GERD patients, and the light blue here, they are the ones who are reflux hypersensitive. So they have a normal acid exposure but a positive SAP. Eosinophilic esophagitis has been, of course, become very popular in recent years, and it's now said that you should take biopsies from every patient with heartburn that you don't understand. I don't think that is particularly practical, and I base my opinion on, amongst others, on this paper from Mexico, where we see that only 4 out of the 150 patients, 6 out of 150 patients with refractory GERD symptoms had eosinophils. Those who had it were, 5 of them were younger than 45. All of them had dysphagia. Many of them had atopy, and many of them had also macroscopic abnormalities in the esophagus. So I would think that it is not necessary to take biopsies in all patients with PPI refractory heartburn unless the patient is under 45 and has dysphagia and/or endoscopic abnormalities. But that's an opinion you may not wish to share with me. We move on to insufficient inhibition of acid secretion. This can be, of course, caused by patient not taking the drug at all or incorrectly, for instance, after a meal instead of before it. They can be rapid metabolizers, or they can have Song-Rasmussen syndrome, which is extremely rare. Probably the residual acid exposure is not of primary importance in the PPI refractoriness. That is, for instance, by this study where they compared patients who failed on PPI and patients who had success. Sorry, I clicked too often. And you can see that there was no statistically significant difference in acid exposure values between those who did well and who did not do well as far as their symptoms were concerned. Persisting non-acid reflux is, I believe, an important mechanism. I showed you this slide before, and this is from the same study where you can see on the left side on PPI, and on PPI a substantial proportion of reflux-related heartburn episodes, we're looking here at individual heartburn episodes, was caused by non-acid reflux. And if you look at the percentage of patients who has a positive reflux symptom association, then you can see that off PPI, it is that these are the dark ones. They have non-acid reflux as the cause of their abnormal of positive SAP. It is substantial, but it becomes massive when you measure the patient on PPI. I will skip this one because it's too complicated for me to explain it. I will just go back into the past and show you that we should have known earlier, because this is a study with esophageal perfusion with solutions of different pH, and whereas 100% of patients felt heartburn at pH 1, there were also quite a few who felt it with pH 4, 5, and 6. So it is possible to have the symptom of heartburn when there is material in the esophagus that has a pH above 4. Hypersensitivity comes into different groups. I think that you can say that there are patients who have peripheral or central sensitization. There's all sorts of evidence. They feel more in their esophagus than the normal individual. It can also be that there is impairment of mucosal integrity, for instance, by dilated intercellular spaces. I will show you in a moment. And the latest news is that it can be that your sensory nerves are located more superficially in the mucosa, and that is the cause of your hypersensitivity. So there are many factors involved in reflux perception, amongst which are characteristics of the refluxate. This is, for instance, reflux events which reach the proximal esophagus are more likely to be perceived as a symptom than those that stay a bit more below. Both acid and non-acid reflux is felt better when it reaches the proximal esophagus. And it has also been shown that reflux that contains a bit of gas, such in the mixed and the gas-only reflux episodes, are more likely to be perceived by the individual. The mucosal integrity can be studied in men by measuring impedance of the mucosa. For instance, by this technique where we used an endoscopic probe that was pushed against the mucosa, and then extracellular impedance was measured. And as you can see here, it is decreased in patients with esophagitis, and also a bit decreased in patients with NERD in comparison with control. You can also take biopsies of the mucosa and put them in an assaying chamber and look at the permeability of the biopsy, and you can see that this is diminished in patients with reflux disease, or permeability is increased, I should say. It's a more leaky epithelium. And you can also use traditional impedance monitoring for looking at baseline impedance levels, and then you will find that impedance levels are decreased in general in patients with reflux disease. There is a correlation with acid exposure. However, there are colleagues who think that you can use this as a diagnostic technique to diagnose NERD, but therefore the overlap is too big. It doesn't discriminate from functional heartburn with sufficient reliability. Here are the dilated intercellular spaces that I had promised you. You all know what they look like in light microscopy and electron microscopy. And as you can see in this slide, there is an overlap between the dilated spaces in between patients with disease and patients and healthy controls. And therefore, it is not a diagnostic tool as some still think it should be, but it is correlated with acid exposure, it is correlated with reflux disease. It is an appealing pathophysiological concept, but overlap with health, poor correlation with symptoms are a handicap, and you can also find dilated intercellular spaces at sites that you have not made acid in a laboratory test. So it is not a reliable indicator of the disease. This is the latest news. I promised you also that the group in London, under the direction of Daniel Seafrim, found that in patients with NERD, the mucosal afferent nerves are located more superficially, closer to the lumen, than in healthy controls. And if you look at the position in respect to the dilated intercellular spaces, these are much deeper. So the theory that you needed to have acid to go through the dilated intercellular spaces to the nerves is wrong. There are patients who have their nerves more superficial than the dilated intercellular spaces. Don't ask me how it is possible that you have superficially located nerves, because I don't know the answer. So, in summary, these were the factors that I've briefly touched upon. For clinical practice, it is most important to distinguish the group who has heartburn but not reflux. They have functional heartburn. Persisting non-acid reflux plays a role, and hypersensitivity, I believe, is very important. So if you do the pH impedance test, you can distinguish 4 groups. You see 3 now already. And number 1 has straightforward GERD. And if they still have symptoms on a PPI, you can try to use more PPI, split the dose, add ranitidine, add alginates, add a mucosa protectant, or perhaps think of a fundoplication. And the same applies to those who have reflux hypersensitivity, with the difference that you can also try here a perception modulator, such as amitriptyline, or even think of fundoplication, but that is, of course, more questionable. And in patients with pathological reflux but a negative SAP, we don't know what to do, but you should certainly not further increase the PPI dose and consider other causes of heartburn. Most importantly, if you have physiological reflux and a negative SAP, then there is no GERD. You should stop the PPI and think of functional heartburn. Thank you very much for your attention.